So good morning, everyone. Warm welcome to this maybe last TOPPENMORGON before you go on vacation. And I'm so happy that we have all of you with us today on this exciting subject about digitalizing Swedish healthcare. So I hope that you are as excited as I am to listen to these great people. We will have some great reports and insights from the best, from Mobile Heights members, Tunstall and Kind app. So, but before starting this, I would like to see who are actually here. So please use the chat because, you know, I'm just looking into a pretty much black camera and no happy faces at all. So at least I would like to know if you are out there, are you listening to me now? If you are, so please use the chat and tell us where you are, who you are, and where you're from, so we can get like a small name tag on you. So please use this chat and tell us who you are. And you can use this chat during the webinar today to ask questions, to comment, to holler, to say happy things or whatever you want. So use it so we can see that you are actually with us in this great topic. And with this said, I would like to introduce today's host and listening a little bit about what's up at Mobile Heights. So Ola Svedin, CEO of Mobile Heights, welcome.
Thank you, Yasmin, and good morning, everyone. I know that there are a lot of you logging on this morning to listen to the topic of today, which will be really exciting to me as well, to hear what's up with what's happening really at the forefront with health tech. But first of all, I wanted to kick off with giving you a quick update on what is happening at Mobile Heights. Mobile Heights, we are growing all the time as a community, and even though there was not a long time since we last met at TOPPENMORGON in May, we have added a few members since then. So we have two new members on board. We have Nordamps, a really exciting deep tech company working with a new novel nanowire design for integrated circuits. We also say welcome to Newseed, a creative IT solutions company. Welcome to Nordamps and Newseed to the Mobile Heights community. Then I wanted to give you a quick update on opportunities that you as a member can benefit from. So I wanted to bring up two specific opportunities. The first is DigitHub missions, where you as a company, you can kickstart your digitalization project with DigitHub. DigitHub is, as you might know, the Digital Innovation Hub project that we are running with other friends in the innovation system here in Skåne and in Blekinge. And it's open not only for companies, in fact, not only for SMEs, but also for municipalities. So check it out. The other one I wanted to mention is the Co-Skill project, where you have the opportunity, again, as an SME company, small or medium-sized company, you can get free training for your staff. So don't forget, check it out on the Mobile Heights webpage and apply to join. So that is all about the update from Mobile Heights. So back to Yasmin for kicking off today's seminar.
And Ola, just before I let you go, why is digitalizing healthcare so important for Mobile Heights to bring up?
Well, yes, a few words about the topic of today. So Mobile Heights have been engaging in the digitalization of healthcare since 10 years back, in fact. And we have seen the sector of health tech growing steadily, slowly but steadily. And I think we are at the breaking point now where we will actually see it taking off, where we have the infrastructure, we have all the components we need for really having health tech taking off. So that is really the theme of today. What's happening out there? What's happening at the bleeding edge, so to speak, of health tech? So looking forward to hearing from Tunstall and from KindApp what's happening there.
Yeah. And I totally agree. And I think all of us agree, whether we're working with these subjects or not in our daily work, we have all been affected on this last year's pandemic, and we see the need for new kinds of solutions. We have seen that need for a long time, but not everyone maybe have realized how much we need it. So it's going to be really interesting to listen to the two great speakers that we will have here today. So first out, I would like to welcome Marianne Bansell, project manager at Tunstall. And she's also have a background as a journalist and a school principal, but always with the IT as a red thread. So welcome, Marianne, with the topic Tech to Care for the Elderly, Challenging Possibilities. The screen is yours.
Thank you. First of all, I would like to thank you for giving me the opportunity to join you this morning. I think it's great to be able to talk about the work that we're doing. Even to be just a small part of the elderly care it's a great feeling, and I know that my colleagues share that feeling as well. That it's a great opportunity to be able to really help people, even if it's just a small part. So let me just first say something about the company. For over 60 years, Tunstall has actually been a part of the elderly care, developing welfare technology, and today we exist in approximately 30 countries globally. And if we look at just the Nordics and the development department, we have headquarters in Malmö, and approximately 60 people work in the Nordic I&D. And when I went to school, I learned about the population pyramid. And this is actually where our business starts to get interesting, because this is not the fact anymore. Today we have more of a population tower, which means that people are, the population is aging, people are living for a longer time, which means that we have fewer people to care for a larger amount of elderlies, but we still need to keep the same level of care. And to look at it in more numbers, we have today approximately 230,000 care recipients within the home care, and this number is constantly increasing. In addition to that, we have 80,000 living in group living, like care facilities. And to care for these people, we have in Sweden, about 135,000 certified nurse assistants. And if we look at this in 10 years' time, we would need to double that amount. And we already have trouble finding staff. And also, we can add to this different kinds of dementia. Since people are living for a longer time, we also have a larger amount of people suffering from some kind of dementia. We can calculate that every fifth person over the age of 80 has some kind of dementia. So it's a huge amount of people. So that means that even if you're physically well, you still need help from home care, or perhaps even move to a facility. And this is where our technology enters the picture, because if we don't have enough staff to do everything that they could do before, perhaps technology can help. So we don't, just as well as we don't aim for an all-inclusive experience when an elderly enters a care facility, we don't intend for the technology to replace the staff, but what we want is to be able to lessen the burden for the staff where the technology can help, so we can keep the same quality of care for the care recipients. Svea here, she wants to be able to live her life as freely as possible. So we have Tunstall, we have a lot of collect the different services, like keyless access, which means that the staff can enter the homes of the elderly without having to go around to the office to collect keys. We have different aids for Svea and her care recipients, friends to call for help. We have fall detection services, different kinds of them. We have something that we call hazardous zones, which means that perhaps it's not good for someone to spend time in another department to where they live, because perhaps they are enemies with someone. This is unfortunately quite common when you get dementia. And then we have video communication. I will talk to you more about that later on, which of course has been highlighted now during the pandemic. And I will also talk to you more a bit later on about fall prevention. I mentioned fall detection before, but of course, if we can catch the fall before it happens, it's even better. Since we are a mixed audience today, I just want to set the stage a bit. So when we talk about elderly care, we have the group living, which is the care facilities where you move to when you are in such bad shape that you cannot live at home anymore. And you also have the independent living, and this is when you actually stay in your original apartment or house, and the staff, they have a schedule in their mobile phones where to go during which time of day and what to do when they reach each care recipient. And to make that as efficient as possible, since that's a great puzzle with all these care recipients and all these staff, you can use the digital care planning, which actually greatly increases the time spent for the staff with care recipients, instead of, for instance, waiting for the right time or traveling about more than necessary. So, as stated here, our goal, Tunstall's goal, is that Birgitta here dares to go on living her life in a free and active way, and doing so by using these different technologies and services that we can offer and keep on developing. So we have, for instance, remote supervision. I will talk to you more about that, and different smart home functionalities, and as I mentioned before, fall prevention. This thing you can see here, the small device, it's a white small sensor that you put on your leg. This is called Snublometon. It's developed by a small land company, and this is really, it's a fascinating device. You put it on your leg, and then it has artificial intelligence that actually learns the individual moving pattern from the care recipient who wears it. So you have it on your leg, and you charge it once a week, and then it can actually track if you're about to fall, because you perhaps correct your steps a bit, and it can actually also catch infections, because you move about in a different way then. So it's really interesting. And we do, Tunstall and Infonomy, the company that develops the Snublometon, we actually do development together. So just to tell you a story, here you have Milo. He has fallen down from a bit of the steps here, and he cannot get up again. So he presses his alarm button, and if he is in too much pain to press that, he has an automatic fall alarm, and the alarm goes to Marie here, the alarm operator who works in the Tunstall Alarm Response Center, where we have certified nurse assistants working 24/7 every day of the year. And they can filter a lot of the alarms, so immediately they understand that to help Milo, they need to send 2 people immediately. This increases or decreases the amount of time it takes for Milo to get help. And also, again, the digital keys, the keyless access, so the staff don't need to go by the office to get the key before helping him. Milo again, he's suffering from a bit of dementia. So he wakes up during the night and he starts to do breakfast. He puts egg on the stove and then he goes out to buy bread. Unfortunately, he does not bring any keys and he does not put on a jacket even though it's winter time. This, of course, is a very dangerous situation since he's living in a small town, so perhaps nobody's out during the night. But with the smart sensors that we can provide, there is an automatic alarm when he does not return home. And another story, Svea here, she's out walking. She gets lost. She's also suffering from dementia. But previous to this walk, they have agreed, the staff, the care staff, and Svea has agreed on different safe zones. So as soon as she exits that zone, there is an automatic alarm which sends the coordinates where she's at, and the staff can get this in their mobile phone app, and then they can help her get back on track. So let me talk a bit about the remote supervision. Remote supervision is a camera service which we can use both during nighttime and daytime, of course. So let's go back to Milo. He's asleep. He has trouble sleeping and he's easily disturbed. And that's why he has chose remote supervision, because the alternative would be for the staff to enter his apartment or house during nighttime to see that everything is okay. But now they can instead look at him through a camera to make sure that he's in his bed as it should be. And this can be performed both from the municipality and from our alarm response center. And it can be done after a sensor has triggered an alarm or for planned visits. Originally, when Tunstall developed this like 10 years ago, there was a huge debate regarding the privacy issues of this. And then we actually stopped providing this service because everybody felt it was an intrusion. And then later on, when everybody started talking to the elderly, we found out that it's actually a less intrusion since you can keep on with a good night's sleep. So this is a service which is greatly increasing, and we're offering this together with Axis, another Lund company, a big one. So what we're doing now is actually that we're developing the backup or the basic platform for the remote supervision, because we're preparing for an additional service which is breaking down now, which more of a video AI solution, where you, instead of having these planned or at alarmed manual supervisions, you have a 24/7, 365 camera sensor supervision. We have different alternatives emerging on the market, but we can still see that it's an early market when you look at the requirements put into tenders, because nobody really knows exactly what to require for. It puts a whole other set of demands on system surveillance, for instance, since it's not enough to know that a camera is online, which is enough for the regular digital supervision, but you need to know that the camera is not just online, but it's actually sending the alarms as well, so you don't get a false security. So as I mentioned, we work with a lot of integrations, and not just to different services, but also we're a part of a greater care chain. So we of course integrate to all major players in the Nordics. So with all these different services, you need to administer them all, and it's quite complex. So what we aim for at Tunstall is to provide one platform, one system where the staff can handle everything, and one place to go to. to connect all these services and get a collected view of the care recipients. And of course, that means that you need to be able to find a collective reports and logs and so on. So we try to work in a human-centric way. The technology needs to be adaptable because each individual have different needs. And we try to make the technology as invisible as possible, because it's not the tech that's interesting. What's interesting is that the people get the help that they need so they can keep on with their as regular life as possible. So just to round off, I want to mention something about the next steps that we're taking, where we're actually providing technology aimed for the end user, because now we have sensors worn by the care recipients or put into their homes, but the staff, it's the staff that's using the technology with the alarm apps and so on. But we are actually developing a family and care recipient portal where both the care recipient and its relatives can go in and see which visits are performed and planned, so that if you're worried about your mother, you know that there has been someone and you know when the next person will come. And as I mentioned before, the video communication. The video communication is a new service where the care recipient can get one or more tablets in their homes, and they can actually call the elderly care, the staff, and say that they want to come in contact, so they don't have to press an alarm, but just say, I want to talk to someone. And also the staff can, of course, contact the elderly, and they can do it both on the move from the app, and if you have someone working in the office who should handle the video communication. So this is quite exciting, and this is a service which, of course, brings a lot of opportunities if you look to it from a pandemic point of view, and what will come after that. So, thank you.
Marianne, this is it's really interesting, and when you listen to, when I listen to you, it feels like this should be used everywhere, because it feels like this is, why haven't we done this before? But I have to ask you, how is it received? Have you seen a lot of obstacles? You mentioned the privacy issue when you're talking about remote supervision, but is there other obstacles that you see that hinders?
I can tell you a story. When I started working at Tunstall, I started as a business analyst, and I was actually visiting a lot of care facilities and following around with home care staff to really get to know the people we work for. And I was prejudiced. I can confess that. I thought I was going to meet middle-aged women who were stressed out and not happy with their work and afraid of technology. And I couldn't be more wrong. I met these great people who really loved their jobs, and they were so positive towards new tech, and they were really curious about testing it and trying it out, and they really liked the technology. So it's an amazing business to work within.
That's really, it's really great to hear, because sometimes you hear, as you said before, about the privacy. Once you talk to the elderly, you see that this is not a problem, maybe for some, but not for all, and that we see the obstacle before we even ask people about it. And would you say that that might be one of the parts why we are not using this, everywhere, or giving the apps or technical tools to actually help the elderly to interact with the staff?
It's a complex question, because, as I said, a lot of people are suffering from dementia, and you cannot, then you need to know that that person is actually willing to accept the technology. Yeah. And also it's a change of work ways, and that's always a process. And then you have the complexity between the municipalities and the regions and the economic part of it. So I think there's a lot of will, both from the municipalities and the staff and the tech companies and the elderlies and the relatives, but it's a journey.
So you see that the will is there at least. That's a very good start.
Definitely.
And obviously you have very, very good examples that this is actually working quite well. And I think a lot of you who are listening to this, I think many of us have relatives or others that actually would appreciate these kind of solutions to get a better care. So I just congratulate you because this is really a great tool. I would like you to, who are listening to this, use the chat if you need, you have any direct questions to Marianne. We will come back. You will be back when we have the joint Q&A with Charlotta as well. So I'll thank you for now, and we will see you in a little bit. So we will go over to the next speaker. We have Charlotta Tönsgård, the former CEO of Min Doktor, and now the CEO and founder of Kind, and a very good kite surfer, I know. So Charlotta, welcome to the screen with the topic, My Early Learnings from the First Wave of Digitalization of Swedish Healthcare. The screen is yours.
Thank you for that kind introduction, Jasmine, and thank you, Marianne, for your presentation. It was really interesting to listen to. So I thought I would use the time that I was given here today to talk a little bit about digitalization in the healthcare industry at large, and also to just share some of my reflections for this, the first kind of leg of this journey in digitalization. But first, just something short about myself so you understand who you are listening to today. So let's see. So my background, I still say, is actually not in healthcare. So I spent about 10 of my first years in the telecom industry, in the mobile industry, doing everything from hardware to software, living abroad for a couple of years, working a lot with Swedish technology, both in Sweden and outside. But since I guess it's almost 6 years now, I've been working dedicated to technology in healthcare. And as already mentioned, this is such an important topic. And I think once you start to look at it and work with it, it's very hard to do anything else. But I think it's always good to start with the why. So why is this so important? I mean, for me, technology is interesting in itself, but technology for healthcare, it's important on a different scale. And Marianne has already kind of touched this topic before, but I think that it's worth to repeat. Because this is not only about creating something new and shiny and something nice for us to engage with. This is actually tackling one of the largest issues that we as a society are already in the middle of, and that is actually not going to become that much better in the years to come unless we actively do something. So the graph that I show here, this is actually numbers coming out of SKR. So it's official numbers. It's a few years old now. And what you're looking at is basically two graphs. So the lightly gray one here, this is about the money that we put into the system. So this is all the taxes and everything we put into the healthcare system to pay for the services that we need. The dark gray area here, or Mount Doom as I sometimes refer it to, this is the things that we actually need to pay for. So if we want to maintain the services that we see today and that we foresee in the future, the dark area here, it's about what we need to pay for. And you don't need to be that good with math or graphs to see that this doesn't really match. There is actually a huge gap between these two. And no matter where you are on the political scale and how you think about taxes or kind of your opinions about this, it is a consensus that we can't solve this by just putting in more money into the system. We need to do something if we want to change this trajectory. And this gap, this is about real people and real services and about being able to provide the healthcare that we want to, but also the healthcare that we can. Because it's not about conserving healthcare as it was in the beginning of the century. It's about having enough space to actually do the things that we want to. And for many, we look at technology as part in solving this problem. And this is also part of the report that came out, talked a lot about what technology can do to help bridge this gap. But I know that there is a lot of skepticism too in this area. Can actually technology be used to save, or are we just adding things on top of an already strained system? So I just wanted to use one kind of real life example from KIND, even though I'm not actually going to spend that much time talking about KIND, just to give an example. So this is Petra. Petra is one of the owners behind one of the largest maternity care clinic or chains of clinics in southern Sweden. They have their base in Malmö. They started using KIND about a year ago. And I assume no one knows about KIND, so just briefly, this is about a technology that healthcare professionals can use to communicate and share knowledge more efficiently with their patients. And when we started working with this group, they choose to use KIND, maybe not to save time, it wasn't their primary objective, but to enable secure communication, basically, to be able to meet their patients in a modern, secure way. But to me, saving time has always been kind of our key motto. I mean, that is why we have the right to exist, as far as I'm concerned. And it's been really interesting to follow this clinic as they adopted the technology. And now we can see that on average, they're actually saving about 30 hours of time each month for each professional. So this is time that is spent, instead of doing one-to-one interactions, to be able to prepare meetings in better ways and share knowledge. So this is just a very small example, but this is the type of things we need to do in order to use technology to start bridging this gap. But if we talk in this room today, I would assume that no one is actually questioning, can technology, or is technology supposed to be a part of healthcare and inpatient interactions? But I just want to kind of remind you where we were just a few years ago. We have a very proud history in Sweden adopting technology to kind of increase productivity and actually give us a competitive advantage compared to other countries. If we go back one step, it was already in 1996 where we actually had the first internet bank in Sweden. And I haven't done my research properly, but I'm still gonna venture to say that we were probably among the first in the world to start digitalizing banking in Sweden. And this is just one kind of step in a very long tradition of adopting technology in Sweden. And we are often proud of being one of the most digital mature populations across ages and very kind of quick to adopt technology in all aspects of our lives. I mean, we booked travels online for almost or more than 20 years now, which is quite incredible. But when I became part of Min Doktor about 6 years ago, a visit to a healthcare or visit to a doctor or a nurse, it still looked like this. The technology was already available to do interactions online with healthcare. There were no new tech that needed to come for that to start to be digitalized. But still, if we look at healthcare and healthcare interactions, this is still how healthcare looked 6 years ago. And I'm not saying this to point fingers or assign blame or anything like that, but I think that it is really important for us to understand why didn't this shift happen earlier? Because this is also part in why isn't it happening, in my view, kind of quick enough now. So I wanted to kind of share a couple of at least my reflections on why that is. First one, and this is probably one of the most important one, is that reimbursement models and incentives, they really do matter. Because if you look at like people working in healthcare, it wasn't that they didn't have ideas or didn't want to apply technology or that they were afraid. I mean, that is a very common view that people they don't want this. They're kind of trying to guard old ways. This is not at all my impression when I speak to healthcare professionals out there. Many saw opportunities, they saw kind of ways of doing this. But in the end, if how we pay for healthcare, how healthcare is reimbursed, what kind of incentives are put in place to encourage trying out new things, if those aren't there, things don't happen. Because it's important to remember, if we go back to the banks in '96, this wasn't triggered by an outside force. When these banks started to digitalize, this came from within the organizations. They chose to do this because they saw that they could and wanted to make things more efficient, and they wanted to start changing how they worked. But if we look at technology in healthcare, this was very much driven by outside forces, talking about kind of new companies coming up like Min Doktor and Kry and so on. They were the ones who drove the change, and then others followed. So if we don't start looking at this, what kind of reimbursement models are in place in healthcare today to trigger change? How are we structuring incentives for healthcare professionals, leaders, and teams to make changes? This kind of change will still come from the outside, and we will still be trying to catch up instead of leading. So this is an area where I can't stress enough how important it is that the ones with the purses, that they actually lead the way in terms of making changes. But I would say that this complexity, it's not a reason not to act. And this I'm speaking, I guess, mostly to other startup founders and providers of technology. Healthcare is complex, and it's very easy to become frustrated and get stuck in stuff. And it's easy to blame others as to why the changes doesn't happen quick enough. But if you are a startup especially, but if you're here to drive change inside the system or not, I would say that the complexity in itself is not an excuse not to act. It is our obligation as startups or as innovators within systems to be part in spearheading that change, and that change needs to come despite of perceived complexity. Using kind as an example, I've tried to get people in Sweden within the kind of public healthcare to use the technology for a long, long time. People who know me know this. But even though that is slow, of course, that can't be an excuse for us as a company to stop working. So we had midwives working with Kind already in the Netherlands years before it actually happened in Sweden, just as an example. And it is possible to also detangle this complexity by understanding who can make decision and who can pay. And also from talking to the buyers, I mean, I would say that it is your obligation to detangle this complexity also for the organization. It's okay that healthcare is complex. It is. We're talking about sensitive data. We're talking about people in sensitive situations. But using that as an excuse to make it complicated for the individuals working in the teams and working in the organizations, so they, in the end, they don't understand even how they can make decisions or what they can make decisions about. That is not okay. And that is something that we really kind of need to address if we're going to use technology as a path to solve these serious issues. So why are we still allowing it to become so complex? I would say that one of the final things I want to kind of bring up here that is also a very sensitive topic is that technology is actually very often, if you apply technology properly, it is very often triggering a redistribution of power. This was one of the most commonly used arguments when I started talking about Min Doktor a few years ago to people. They were saying like, okay, but that means that, sorry, that means that the patient gets to decide when they need help. If you allow the patient to start triggering the interaction with healthcare. Sorry, I actually swallowed a fly. Oh, terrible. So you actually trigger a redistribution of power when you're applying technology. Like if you're going to your hairdresser or you're booking a journey or you're checking the accounts for your banking account, you as an individual, you trigger that interaction and no one can tell you not to do that or how to do that. This is a very sensitive topic when it comes to healthcare. What are we as individuals, especially I would say in a publicly reimbursed system as Sweden is, what are we as individuals allowed to do and trigger by ourselves, and what should the system kind of funnel us or force us to do? But this is not just about redistribution of power between the individual and the healthcare system. This is also about redistribution of power within teams. And what I find interesting is that we've seen the same kind of journey looking at companies outside of healthcare. One of the most kind of easy thing to reference to is the bring your own device development within companies. If we go back 10 years in time, small company or big, there were a central unit at most companies that decided what type of phone you could use and what type of systems you were using. And they were the ones who kind of set up the infrastructure of IT for a company. And as we started using Androids and iPhones and new kind of apps came into the working environment, such as Slack and other types of communication tools, where it could actually be triggered by an individual team or a set of users to start using it, this was really sensitive to most big companies. And it was seen as a risk for security, and it was perceived as kind of increasing cost, and a lot of different kind of discussions were ongoing in most big companies 10, 15 years ago. But in the end, and the reason why I would argue again is because of this redistribution of power. But I also believe that if we want to have a high pace of development within healthcare, we need to allow the healthcare professionals to be part in making decisions about their working environment. The central decision should be about setting the frameworks and the tools and kind of setting the protocols that you need to apply to, but then you need to trust the professionals to actually make decisions about their own working environment if we want to see a real pace in development in this area. And then as a final note, coming back to this mountain of doom, there is a fear that technology is actually increasing the cost and not saving it. And as the example I used with this midwife clinic and the money that they saved, this is how you're supposed to apply technology. Technology is supposed to pay for itself. That is the whole purpose of using it. You can use it to make something better, but if not making it also cheaper, I think we're really missing the mark here. But that means that we need to be prepared to change how we use our time. But it also means that we need to be prepared to change how we pay for things. If we as a company, if we said we would actually base our business model on how much money we saved at this midwife clinic, and that is what they should pay us, then we don't have a business model that scales into the future as I see it. Technology should be paid by a lot of people paying a little bit. And that is how we actually fuel the development of that technology, and then redistributing back the knowledge and the things that we learn from using a lot back to the individual team. But that means that also business model and reimbursement models needs to follow this. One of the challenges we have as a company is that we are so cheap that we don't actually fit the model. Like, you can't spend hundreds of thousands of Swedish crowns to make a study to prove something if in the end the team would only pay a couple of thousand crowns a month to pay for the technology. So again, in order for us to really apply technology in a good way in healthcare, we need to accept that reimbursement models and incentives, they really do matter. And this is something that only the ones with the purse can make changes to. We need to acknowledge that healthcare systems are complex, but that is not an excuse for us not to act, neither as companies or as people holding the kind of the infrastructure of it, or the big companies providing healthcare as a service. And then as a final part, technology can and should redistribute power. And this is something we need to accept and take with us into the future. Thank you for listening.
Thank you so much, Charlotta. It's so interesting, and you. I think that all of you that are looking at this webinar hopefully agree that there is so much to be done, and there are so many question marks on this. Why aren't we doing more on this? And you have pointed out some of the obstacles, and turning back to this distribution of power, who would you say is feels the threat the most, so to say?
It's a good question. I mean, I think it very much depends on which country you're talking about. I think in Sweden, probably the most tension in this distribution of power is probably between the public system and the private one, which is a bit unique for Sweden because we have so much public healthcare spending. Because I know I've spoke to I'm not going to name any names, but I spoke to someone part of a big region in Sweden. I'm not going to point fingers. And we had a discussion about patient data, because you have to remember, in healthcare today, I as an individual, I don't own my data. My data is owned by the provider. And we had a discussion about that, like, what does that mean, and what should that look into, how should it look into the future? And to me, because if you're a big company or a big region, you want to use my data to be able to draw conclusions from it. And it's really powerful and it's great in many ways, but it's also cumbersome from a legislation perspective. How can you use that and so on? And to me, the answer was really, really simple. If you just accept that it's the individual who owns the data, and I have the right to lend it to you if I want to make conclusions from it in groups, then this is no problem. But if you want to remain in power over my data, then there is strong limitations to what you can do with it. So I think this tension in Sweden, it's definitely between private and public, probably. But this is just an example. You would find the same tension within a large company. If you look at like a large healthcare provider or a chain of providers. So I think this is a natural and good one. The problem in Sweden is that since so much of the funding is actually tied up in the public system, if that doesn't start to work in a much more constructive way, it actually becomes a blocker for development.
Yeah. And it's interesting to say, I mean, coming back just to the who is owning the data, I was talking to one person treating me and asking for the information about myself, and we had an argument about who is owning the information about me in South. So, you know, it's like, well, isn't it that about me? And that's what you're pointing out here, that actually there's interesting discussion on who's actually owning data about myself, and comparing to the bank system before. I mean, it's, if you turn that discussion into the bank system, should the banks own everything or me concerning the data? And we have a question about that. So let me see here. Disappeared. It's a long question. Even though healthcare related data is sensitive in the internal exchange of information data between different actors, public and private, would greatly benefit both parties and can be done better. What would you, Charlotta, say is the biggest obstacle for exchanging information in the healthcare sector, excluding sensitive data aspects? So that's a little bit.
I mean, I'm definitely not a security expert, but as I said, I think one of the most important steps is to acknowledge that the data is the individuals.
Yep.
I think if you take that step first and you acknowledge that, yes, it is the individual who owns the data, I think a lot of things actually is solved. But then the second part is trust. I mean, I've had so many discussions about with people about, can the individual be trusted to make decisions regarding their own data? And I think here we also need to start acknowledging that we need to, if anything, if we don't trust them, then we need to start educating people about how they should handle their data. But in the end, that is not an excuse for others to say that they are better than me to handle my data. Yeah. So I think trusting the individuals, putting the control in the hands of the individuals, whatever that needs to be saved about me for security reasons, talking about medical records, that should be very, very much limited. But what I store data for myself and how I choose to share that, that needs to be kind of confirmed.
Yes, we have another question here before I let Ola and Marianne come back on the screen. How can we make sure the incentives and power is directed right so the people who need care get it? Today with Min Doktor, etc., an unnecessary demand is created. Basically, young people who used to just ask their mother for advice create costs in the healthcare system, whereas good quality tech solution may not be affordable enough by the elderly who need it. So how to incentives and power right?
I think it's such an interesting question, Martin. Thank you for asking it. I mean, I do find it a bit curious when people say that a demand or like a need from me as an individual, that is unnecessary. I think that is actually not like how I would phrase it. Like if I feel I have a need, even though like 20 years ago, that would be handled by me speaking to my grandmother, I'm not necessarily think that is the right solution in general today. What is correct, though, is that just because I feel I have a need, I have a worry, I have something that I need to get help with, it doesn't mean that I know what the correct reply to that need is. And that is the healthcare system's responsibility to help guide me. So just because I feel something, I have a tingling in my hand or have a rash that hasn't gone away, maybe it shouldn't be treated by medicine. Maybe I should just wait and it will go away. But it's not my responsibility as an individual to know that. Guiding me to the right solution, that is the healthcare system's responsibility to do. And if anything, we need to be even more preventive. And if we then tell people that they're not supposed to burden the system by asking questions, how can we ever become preventive? So I think I don't agree with that way of phrasing it. What I do agree with is how do you then reimburse that ask? And that I think is the key. Like, what is the reimbursement for answering my question? And that I think I know that there's been a lot of modifications the last few years. I think we're very far from reaching a conclusion to that. Like, is it just because I text my healthcare provider and they answer me something? Is that equivalent to a visit? Like, should that be reimbursed in a similar way as if I showed up to the healthcare clinic and they needed to do something with me? I would say that it's obviously no to that question. So I think when it comes to reimbursements, when it comes to how to pay for it, I think a lot is kind of left to be done. I really don't agree with putting that responsibility on the individual.
Thank you. Great answer. And I think that's, you point out that this is a complex system, obviously, and you need to bring all the different parts to the table to actually understand and actually, see what is what and get paid or pay for whatever it is, but not just have one system for everything and not really figuring out what it is. So I think that's a great answer.
And I think
yes.
The cost for these digital care providers compared to the costs of the healthcare system and the inefficiency we have in them, it's mind-boggling. It's not even on the same scale.
Exactly.
Just look at the example I gave with the savings you can do in maternity care by just applying some simple technology. It doesn't have to be from Kind, but just by applying common sense.
Sounds like a public service.
No, but yeah,
others.
What is the money in that bag compared to the money that is spent on these perceived unnecessary visits?
Yes. Yeah. Looking at the whole picture and actually understanding what this can actually bring for savings, both for lives and health, but also for the economic system, obviously. I'll bring Ola and Marianne back on screen, and I have a direct question to you, Marianne. How can municipalities work differently to make this technology shift happen, aside from spending more money?
Well, like Charlotta said before, technology should actually pay for itself. So the idea is that if you initially spend that money, you actually gain it back and more. But what you need to do, well, you actually, like Marianne Blomqvist in Hammarö kommun said when she talked about the digitalisation journey that Hammarö has made, just do it, just start. You need to start somewhere. You can talk to other municipalities who has come longer on their digitalization journey and learn how did they do it, and start small. You can try something out in one care facility. You can start in one group and so on. You can start with one service and add on and learn from others and just do it. And of course you will have. Every change equals a job and adaptations and so on. So it's a journey, but start.
Good. Just start. Just do it. Yeah. Ola, do you have any questions to these great speakers today?
I certainly have questions, and I will try to pick for me the most burning issue. Perhaps I see such passion from Marianne and from Charlotta in the work you're doing, and you said a few things, both of you, that I picked up on, and Marianne, you said the objective here is to increase the time spent with the care recipients, and I think that's. For me, that's central to this, and we have talked about the economy, about this, that the technology should not only pay for itself, but actually, add value when we introduce it. So my question to both of you is: are we past the point in the public conversation where this is an established fact, or do we still need to have that discussion in the society, that introducing the technology into healthcare is good. I mean, is everybody on board with that? Do you think that we are past that point, or do we still have some journey to make here?
It depends on how you look at it. Of course, we're past that point, but still you need to question. I mean, not all technology is good, and you need to use the technology in the right way, not just technology for technology's sake.
I wish we were past it, and I think we're past it from a political correctness perspective. So, I mean, it's not okay anymore for anyone to say that technology isn't part of solution and so on. Like if you compare it to 5-6 years ago, where that was still okay to question. But I would still like, if that it would also be true, like truly true, then I would assume things would go quicker, because the sense of urgency, I mean, looking at money, I think 1/3 of all regions in Sweden, they have a deficit. 1/3, 30%, I think it's like 25% of all municipalities, I can't even say that word, has a deficit. So this is a burning house. So if the house is burning and everyone is agreeing that technology is a part in solving this, I would assume it goes quicker. So I would say that from a political correctness perspective, we're way past it, but from an actually kind of absorbing this and seeing that if we accept that, that also means that you need to do actions. You can't wait 3 years for things to change. You need to do things now. Then I would say that there are probably still kind of things not worked out, unfortunately.
There's some way to go. Yeah.
Goodness, I feel, you know what I think? If I had a vote, I would like you guys to be kind of the ministers for health in Sweden. We have an option now, maybe. And you can just grab this, and you need, because I think we need to do this quite fast. And as you said, Charlotta, we have a lot of deficit, and we have a lot of urgent matters to actually solve, and we cannot wait. I see this in my private life. I have a lot of elderly people around me. I see it, people that are, I mean, we have seen it, all of us, during this pandemic. There is a lot of things that are not working, and there are not enough and fast enough solutions, I would say. So I would vote on you guys. What do you say, Ola? Are you with me on this campaign I'm starting?
Yeah, I'm on board with that, and actually I want an opinion from both of you as well, Marianne and Charlotta, on one topic. I mean, this week Sweden again were ranked #1 in innovation in general, innovation in general, by the EU Commission. They have this index that they publish every year. So actually Sweden was on top again. When it comes to health tech, can we say that we are in the forefront as a country? Are we on the leading edge, or are there other countries that are more advanced than we are at this stage? What do you think?
Well, we're definitely on the forefront. When it comes to robots, I believe that Japan is further than we are. But for the kind of services that I have been talking about, and Charlotta, yes, we are part of the world leading communities.
Again, maybe I'm on a opposition mode today, but I would be, I mean, yes, I think we're in the forefront of thinking out new things, and kind of I can see that from an innovation perspective, we are definitely on the forefront. When it comes to applying it at scale, I think we're good. I mean, again, remember, we're so proud of Min Doktor and Kry, and we think that is kind of pushing things. It's like a small percentage of all healthcare. So I think that we are probably in the forefront maybe of thinking out things and making up new stuff, if we're on the forefront of applying it. If we look at it as a country, maybe, because we're a small country and it's still kind of a lot of public pay, and there's things in here, but I'm not sure we are leading. Like if I would look at a country, where do I see the future of healthcare, like at scale? Is that in Sweden, or would that be like a private healthcare chain in Israel? I'm not sure.
That was thank you, a good wrap up, and the future will tell, right? And I wish you good luck with what you are doing, because you are really true heroes here, and keep up the good work. And Ola, just to wrap it up, what would you say that you bring with you to Mobile Heights?
Well, you know, as I said, a few things stand out for me, and one of the things that I think is so encouraging is that we see technology being applied now, that the solutions are actually being put to use. I mean, Marianne, you mentioned the Snubblometer as one example. That's Infonomy, a small innovation company in Lund, and that company, we have seen that they have been on the radar a couple of years, and now their particular solution is actually being used. And that's just one of many examples of innovations that have been, you know, in early pilot testing and perhaps a few users, but now it's being rolled out. So that is something that I take with me. That's a really, really encouraging sign that we now see all these solutions being rolled out.
Yes. And thank you for doing this. And I think we need to roll it out even more, or you know, show it to the world. So thank you for arranging this, Ola. And for you guys who want to talk more about this interesting subject, you can go into LinkedIn, to Mobile Heights LinkedIn site, and you can discuss this subject further. If you want to get in contact with anyone of the attendees or of the speakers, you can just send an email to molly@mobileheights.org. I think that the email is in the chat as well. So, and it's 11 o'clock and it's time to wrap up. And thank you again. Thank you, Charlotta. Thank you, Marianne. And thank you, Mobile Heights, for arranging this really interesting talk. Have a great summer if we don't see each other before.
Thank you.